All right, everybody, please be advised. I'm going to record this meeting for note-taking purposes. Anything said in the meeting, viewed on the webcam, or typed in the chat could become part of the recording. And I think we're all set. Thank you.
Thanks, Shelley. I'm going to go ahead and share my screen. And then it's going to make me quit Google Chrome, Shelley, to share my screen. I'm going to have to come right back.
Oh, that's a bummer.
Sorry
Did
about
that fix it?
that. Should work now. Every time I do this, it makes me want to go to my system preferences and allow me to share it. And then I put the screen. Okay. All right. Can you guys see the PowerPoint?
Yes.
Cool. Okay, so I put together some stuff that you all sent to me, and then we'll kind of see where we get from here and see if there's something else we want to add. Do we need to do the minutes, Shelley? Do we have to approve those or no?
I left them vague.
Okay.
If there was anything wrong with them, somebody let me know and I'll edit whatever needs to be edited.
Okay, perfect. Let's see here. Okay, so maybe the easiest way will be, I'll just kind of buzz through these and then we can kind of see if we want to add anything. So what I had started with was putting in information that Matt had given me about physiologic changes during pregnancy. So the first couple of slides have to do mostly with that. So he sent me a sort of a table of changes and I kind of broke them up by airway. So there's kind of a lot of info on here, but I think it's kind of good. So what the airway problems you can have during pregnancy, what causes them and how you manage them. And then breathing changes. So similarly, what causes, more difficulty with breathing in pregnancy and how you could manage it. Cardiovascular changes. So these are sort of general things, right? Could require greater fluid resuscitation. I mean, this could go for anything, cardiac arrest or trauma or whatever. And then a little bit of information just about pre-hospital obstetric events, trends in maternal mortality. So maternal mortality has gone from 7.2 to 17.8 deaths per 100,000 in the United States.
That's not the right direction.
No, it's not the right direction at all. And it's not what other, so it's happening in other countries, just our country, apparently. So pregnancy-associated deaths, I don't know how important this is. It just really kind of talks about, this we probably don't actually need.
I think you can probably take that one out.
Yeah, that's super
helpful for other reasons, but maybe not for this.
Yeah. What about this one? This one too?
Yeah, I mean, I don't know if you need to know.
Okay.
There is something that we could do where we do have preventability stats by preventable deaths while people are pregnant versus labor and delivery versus postpartum. Most of our deaths are happening in the postpartum phase, so that might help sort of build the rationale for why EMS providers should take postpartum emergencies as seriously as emergencies during pregnancy or something like that. I don't know.
That's a good idea. So let me put a slide holder in here. So
I can send you that.
this is going to be stats for preventable deaths.
Preventable deaths by timing during pregnancy. I'll send you a title too that makes sense.
I'll just leave that in there. Okay. And that will be the rationale. And then I think you had sent this to me as well, Clark, right? This urgent maternal warning signs.
Yep. So these are just the ones that are coming from Council on Patient Safety and our Hear Her campaign. So there are a lot of them.
There are, but I actually thought it was good. So if you look at what I kind of went through the NCCP curriculum, what's required for paramedics to take education-wise, because I initially thought maybe we could combine it so that this education would also cover all of the NCCP required stuff, but it's so different. Like it really just talks about delivering a baby. Like most of the NCCP stuff talks about stuff during delivery. And while I think it's all obviously valuable education, something they have to know, I think obviously what you guys had identified that was missing or what people didn't know enough about was some of this stuff. So, if the group has a different direction they'd like to go, totally fine as well. But I thought what you had sent me was actually really good. So I'm going to flip through these slides that Clark sent just so that we can you can see what's in here. So it gives a little bit of explanation about the campaign and talks about why certain symptoms in a pregnant or postpartum patient could lead to or could be warning signs of something more life-threatening than you would think of if it wasn't someone that had had a baby. So this one talks about headaches that won't go away or get worse. So each of these slides gives a set of symptoms and then a potential warning sign of, and then it kind of talks about the things that it could be. And I think that the explanations here do seem fairly pre-hospital appropriate to me. Dizziness or fainting. So again, some things here, I think that they are very general and very pre-hospital sort of relevant. Changes in vision. So warning signs of preeclampsia, fever, again, infections, extreme swelling. This one's more about severe depression, trouble breathing.
I did mean to move the mental health ones just together, so we can do that later, but to maybe pull that one down. There's one or I can't remember if it's 2 or 3 slides total, but the mental health ones are a hard tie, I know, but
okay. And the only thing I can think of now that I'm looking at this is maybe because we don't really talk about preeclampsia much in the pre-hospital setting, maybe like a single slide about what preeclampsia is.
Sure. Yeah.
Could be helpful because I think that comes up a lot in here, and I don't know that it's a very familiar thing to some EMTs or medics.
Okay.
Chest pain, severe nausea, severe belly pain, maybe movement,
so maybe preeclampsia and HELP syndrome, maybe.
Yeah.
Placental abruption. Okay.
Mm-hmm. Vaginal bleeding. Yeah, placental abruption might be a good slide too to put in there.
Mm-hmm.
Severe swelling, overwhelming tiredness. And then I went into the stuff about the crashing pregnant patient. So this was sort of a little bit something separate. So urgent maternal warning signs, dangerous things that could happen to pregnant women or postpartum women, and then the crashing pregnant patient. So what would you do if you had a patient that was, not just sick, but like actually crashing? And we had kind of talked about that as well. So I'm hoping we can marry these into one presentation. So talking about cardiac arrest and the causes being really very similar to other causes that would cause someone to go into cardiac arrest. and then kind of took the information that Matt had included and broke these into sort of more actionable items for things, like if someone was crashing and they were pregnant. So oxygen reserves being lower and needing to provide more early ventilatory support, starting with a smaller endotracheal tube would be a good idea in a pregnant patient. And then making sure that you're not being too, forceful or aggressive with laryngoscopy to prevent additional bleeding. The cardiovascular ones, same thing here. So this one, we talked about putting the IV above the level of the diaphragm, and then in cardiac arrest, just sort of clarifying things that might not be commonly taught, but medication doses do not require a change. I'll have to put the references to these in here. You don't have to change the dose in cardiac arrest to accommodate for anything. And we don't want to withhold any medications in cardiac arrest in pregnant patients because of concerns. And then in here, we sort of bring up this issue of manual lateral uterine displacement should be performed if they're big enough or pregnant enough that the uterus is palpable. And then I just have kind of a picture here of, we can't do good CPR. The explanation here is we can't do good CPR on a wedge, right? So we've gone away from that idea so we can provide good CPR while someone displaces the uterus. And then the last slide here was talking about transport considerations. And this is an American Heart Association recommendation. So we can kind of talk about if that's relevant in our region or not. And so that's where I am. That's kind of what I got put together. There's only 30 slides. So now we can kind of chat a little bit about it, and you guys can kind of let me know what you think.
So I apologize. I did not understand the assignment. I brought a couple of slides that I made just with me today. I put them in the chat, and I also sent them to your emails. They're just links to. First of all, this slide set is amazing. It is really well thought out. The graphics. There's not too much content. There's not too little content. It's perfect. And so from the last meeting, we came away with, or at least I came away needing to look at fluid resuscitation and the use of pressors.
Oh yeah.
And as we kind of suspected, there wasn't. You'll notice my slides are somewhat minimal because I didn't want to overload information that really doesn't need to we don't need to reinvent the wheel. There wasn't a lot of considerations. It was largely follow ACLS, a little bit of consideration for fluid resuscitation, maybe a little bit earlier consideration of it, but there was nothing that pointed one way or the other for any selection of pressor or anything like that. So it was just kind of a recap page, and I think it goes nicely. I think it'll fit nicely right in there with your crashing patient slides. I think it's
yeah. So let me put that in. I'm gonna add a slide.
Sorry about that. I apologize, group. There, everybody else did their job, and I kept.
No, it's not that much to insert now, so
sure,
totally fine. Can't figure out where to put that. Resuscitations. Let's put a new slide in first. And then your little mnemonic. So you had 2 slides, right?
Just 2, yeah. Reversible causes specifically for the pregnant patient, and then
maybe Dr. Rice, you were talking about adding like a preeclampsia and help slide.
Oh yeah.
So maybe like right before the crashing patient, that's where the preeclampsia and help slide, and then these 2 slides would go, and then the crashing patient would maybe be the last. Would sort of be like the last in that order. So not that help or preeclampsia are not critical conditions, but the crashing patient is probably the most critical. So we just sort of like stack them that way. That seems like it would flow nicely.
Okay, let me share this then. I'm gonna have you say that one more time as I go back to this. Okay, so say that one more time, Matt.
So I was just saying, like right where the crashing slide patient is,
okay.
The slide for the crashing patient. Before that would be like the preeclampsia and the help slide.
Okay.
And then these 2 slides, and then the crashing patient, because like his first slide like kind of speaks to a little bit of the treatments for kind of all of those things, like basic resuscitation.
The HELLP, right?
Yes.
Remember it. slide, then this, then his at the end, right?
Yeah, I think so. Or even maybe that one after the like I can't quite see what it says there.
Yeah,
Maybe like 2 slides down.
I lost my place. Where was I? Okay, so
Maybe the preeclampsia and help. Well, no, I think that's probably right there, because then the other ones are kind of general.
or we can kind of put them. We can put this at the beginning of the presentation. Or do you like it at the end?
I kind of feel like at the end is good, because the other slides talk about like things to recognize and things to look for and basic things to consider, and then this is like these are a couple specific like syndromes or something like that.
Well, maybe I should talk about his reversible causes then.
Ooh, yeah.
Here.
I was compelled to add that in there because I saw that there was mentions of the reversible causes, even though they're truly reversible in some cases. I saw mentions of the reversible causes elsewhere in the slide deck, and so I kind of felt it. I was urged to include those things. So.
Mm-hmm.
Not to cloud this, but I do think it might be worth for the urgent, like the initial urgent maternal warning signs slide, we can reword it a little bit. I don't know what you call non-crashing patients or something like that, but we can change the wording to say, for patients that are not crashing, whatever, not in serious emergencies, their attention is still needed because of the potential risks. Like, here are the symptoms, here are the potential risks. Like, patients are being instructed to call 911 for these things. So don't dismiss it for nothing, I guess. I don't know how to say that better. But that's sort of the intention.
More stable patients.
Right.
You want to put that in this slide, like change some of this to say.
Yeah. And I can adjust some wording for you too, but I don't know if you want to urgent maternal warning signs for non-crashing patients or something like that for the actual title.
I'm going to just say like serious symptoms or serious conditions.
Yeah.
To watch for.
Yep. Anything like that works.
Yeah. Okay. Oops. Yeah, I think I might just make it a little bigger. And Shelly always makes these really pretty, so. Okay. Maternal signs. These are serious things, blah, blah, blah. Okay, now this part was where we were a little bit stuck. So we had long tiredness. I don't know if I need like an introduction slide.
Maybe we can introduce the kind of this from here on as the unstable patient as kind of opposed to Clark's more stable patients. You know what I'm saying? I don't know. Just a thought.
Yeah, I agree with that.
Yeah. Let's go to. Unstable pregnant patients?
Yeah, right. I mean, yeah.
Yeah.
Can't.
What do you think? Give me something better.
I just think can't you still get like the hypertension? Can't that happen for a certain period after pregnancy also?
Mm-hmm.
Yes.
Right. So maybe saying unstable pregnant patients might not be
You could say
100%
pregnant
accurate if they're not pregnant
Yeah,
anymore.
yeah.
pregnant and postpartum
Maybe we
patients.
should still, pregnant and postpartum. Yeah, I agree with that. Very good.
Yeah.
Yeah, that sounds good.
Okay. Then we have the crashing pregnant patient. So we talk about cardiac arrest specifically.
I think maybe that slide should go farther down.
Yeah.
Do the other ones first.
Okay. Where are we going to put that one? Like right here with this one, maybe?
Yeah.
Oh, it's going to be different. So now we have, and this is kind of like, did we decide if the doses of pressors needed to change?
That I couldn't find any real research on. I was even hesitant to put in what little research I found about the preferred type of pressor, which seemed to be epinephrine, but I kind of pressed that against the choices that pre-hospital medics have in pressors, which is only between dope and epi. And that's further constrained by standing orders. And so I just didn't want to overload the slides with information. And so I was hesitant to give a dose because I think an ACLS book will say one dose and perhaps another textbook will say a different dose. So I couldn't quite come to a consensus on that.
Just trying to see if there's anything that says like, you're going to need a higher dose or.
I thought
I
I
thought
could
there
be
was
wrong
a
about
slide
this.
that said that you didn't need to change your doses based on pregnancy.
For cardiac arrest medications specifically. I don't know. What were you saying, Matt?
I thought I remember looking into this a couple years ago when we were redoing our protocols, but I seem to remember the preferred pressor was phenylephrine and then Levophed. Now, I don't think any ground EMS carries phenylephrine, but Levophed they might if they had an IV pump. Otherwise, it'd be epi and dope.
Mm-hmm.
Yeah, ephedrine and phenylephrine have been the most investigated.
Yeah.
Low propensity for uteroplacental vasoconstriction. Maybe that's one more piece we have to dig up.
Yeah, I think ultimately though they're going to be constricted by what they carry and what their protocols say.
Pretty much. I don't think that there's any reason not to give it though, right?
No, not that I could find anyway.
Okay.
I don't think so. The scenario in which you're pushing a pressor is I mean only reserved for a couple of different items, and so I don't think it changes. I don't think a pregnant patient changes those scenarios.
Yeah.
Like you were just saying, is there a reason we don't give dope? I don't think so.
Yeah.
Yeah, if we're administering pressors in the field for this, it's gone downhill pretty badly.
That's all I could think about was
Yeah.
like I'm trying to put myself in the scenario where I'm doing this and I'm going, it's just bad every time I think about it.
Yeah.
That's funny.
Yeah. And really, I think the point here is that, they may need a slightly higher, fluid bolus if you're big and pregnant because the blood
Sure.
volume you need to replace could be higher. So, sort of, making sure that you're good and fluid resuscitated, I think is probably the most important point.
Yeah.
Okay.
Maybe.
I think the slide set is fantastic for the second meeting of the work group. That's a fantastic product to have put together so quickly.
Do you think maybe for the fluid resuscitation line there, we should say something about like targeting a systolic? Because you saying 20 mLs per kilo, that might be like your bolus doses, but you might give quite a few of those as compared to a normal patient. So
Yeah.
maybe
So
saying some,
say target.
targeting a systolic of 90 or at least a MAP of like 65.
Yeah. I'm trying to figure out how to say this. Because obviously your target would be different depending on what you were treating.
True.
Target goal SBP.
Like I mean, we could just be general and say to maintain perfusion, and that's sort of open ended unless you want to be specific with a
target
metric.
to maintain.
Adequate perfusion.
Yeah.
Nice, very good.
Target goal SBP to maintain adequate perfusion, urgent pressure, therefore higher volumes of fluid. Yeah. Oh, it's okay.
Yeah, I think that sounds good.
Absolutely.
Can you come so quickly? And then we have, these are reversible causes of cardiac arrest.
I kind of called these maternal H's and T's, if you will. So I don't know. Maternal reversible causes, even though they're not. Some of them aren't truly reversible.
I never use the word reversible causes because I get so mad at the H's and T's.
Sure.
I'm like, you can't fix any of that. Quit calling them reversible.
Right. Yeah. For us, it's reversible just so we can say we documented it doing it.
Right.
It's causes of collapse is a term that's
Oh, nice. Yeah, that's a much better word.
Yeah.
Okay. So we have bleeding, DIC. Do we need to spell this out?
Oh, I didn't think to do that. Yeah, sorry.
Probably.
Or I could.
Well, you know what? I don't think I can spell it. I probably subconsciously protected myself.
I could put coagulation abnormalities or something that's a little more general.
Yeah.
Like hemorrhage. What's the right word there? Or DIC. Oh, yeah.
And maybe coagulation problems. I don't think they're going to know what DIC is. It's very complicated. Emboli, coronary pulmonary amniotic fluid. Okay. Anesthetic complications. Do we want to keep this one? I guess we can.
I didn't know what to do. It was in there. It's one of the parts of the acronym of BOCHOPS, but I've never, it's not something we're looking for in the field setting.
Yeah, but you could be called, well, yeah, but it would make sense. Uterine atony. This is like immediate postpartum. Cardiac disease, cardiomyopathy, aortic dissection, hypertensive disease, preeclampsia and eclampsia, H's and T's, central abruption, previa, and then sepsis. Okay, cool. And we're going to do a slide specifically for the other one?
Preeclampsia and help.
Preeclampsia.
Yeah, eclampsia. Okay.
Oh, Dr. Rice, could you put the acronym BOCHOPS on that slide? I don't know. Just to kind of spell it out, I guess.
BAUCHOPS. Yeah.
Thank you.
Perfect. Thanks. Okay. Anything else that we need a slide to define or explain a little bit more besides the preeclampsia? Do we need to describe any of these other things in the BOCHOPS? Like,
I mean, for the placental abruption and things like that, like, is that something I'm not never been an EMS provider, so I'm not sure how far that gets in, or even the uterine anatomy and things like that.
That's like part of like the initial education and
Yeah.
part of your like buy-in or your every 2-year refresher.
Mhm.
In theory.
Do you think that would be recognizable though, Matt? You don't think we need to go in too much to that?
Absolutely, I do. I think it's absolutely recognizable.
Mm-hmm.
Okay, perfect.
Standard knowledge in paramedic school, I think.
Perfect. That's great.
Those are the really scary things, so they get talked about.
Remember
Yeah,
that?
right.
Things we'll probably never see, but maybe.
Right.
Okay, so we have 29 slides, 33 now. And what about this transportation one? How do you guys feel about this one?
Is that options in other places? Like up here, there's only the one facility. But
yes.
in Phoenix, would you pick?
Yeah. So for here in Tucson, we have a protocol for, like, one of our regional transport guidelines is the critical obstetric guidelines. So we have different levels of obstetric capabilities at our hospitals. Some are, I can't remember what the name of the levels are. It's like 1, 2, 3 or whatever. But the level 3s will be able to take care of, they have like, they could do preterm deliveries, high risk things. They would all go to one of the 2 places that have a NICU primarily, like preferentially, because you'd always have a neonatologist on staff all the time. And then other pregnancy things could kind of go anywhere. I think ours is set at like, I'm gonna say it's 30 minutes. If you have to drive more than 30 minutes out of the way or something like that, I'm trying to remember what the exact number is. But this one just says, you know, you shouldn't. This is for cardiac arrest specifically. But you wouldn't want to go more than 10 minutes. But those are just for labor-related things, basically. But if someone was in cardiac arrest, I think they would go to the closest.
Yeah, I can't imagine someone electing to go to a quote obstetrics ER or hospital, and that's farther away than a closer hospital for a patient in cardiac arrest. That would just be.
Yeah. I think for our purposes, and we could ask other folks on the education committee too, but like for us, we have a lot of freestanding emergency departments. Like I definitely would not expect a freestanding to be able to do a perimortem cesarean.
Sure.
But any of our other bigger hospitals would. But I feel like the providers would know that.
Mm-hmm.
Maybe we don't need the slide. What do you think?
That's exactly what I was thinking. I would hate to kind of give some information and then you're kind of locked into that hospital being the one you want to go to, rather than thinking critically going, do I have the time or do I not have the time?
Okay.
I was just thinking maybe saying something in the slide that was like, you know, just to make it clear that it's maybe not speaking about cardiac arrest. It's about the other indication, the other patients, pregnant patient populations. So they might still be at high risk. They might be preeclamptic and seizing. So in that case, it might be worth driving away from the standalone ER to a more specific or specialized facility, or no.
Yeah, I mean, this one is about cardiac arrest, though.
Right. That's what I'm saying, is maybe making it not about specific to cardiac arrest. Yeah.
I don't know. I feel like people probably have protocols.
Okay.
I guess. I don't know. Maybe we should just delete it. What do you guys think? Gone?
Yeah, I think delete it. We're talking about paramedics here. I think they have enough sense to go to a closest hospital if someone's in big trouble.
Big trouble. Okay. Oops. A new slide. Oh my God, what's happening? I'm just gonna leave it there. Okay. What do you guys think? Anything else we need to add? Or do you like the length of it?
I think the length of it's good. I think too much and no one's going to go through it all. So.
Yeah, that's true. Okay, so I can get those stats from.
Yeah, I'll send you the preventability stats, and then we can. Do you want us to do a quick slide on preeclampsia and HELP, or
Sure.
somebody else? Okay.
Sure. You want to do both of those?
Sure.
And then I'll add those in, and then we can. I can shoot it around to this group for you guys to all peek over and make sure you don't have anything that I missed.
Sounds
and then
great.
we can hopefully get it on the agenda for Shelley.
Thank you very much.
No, thank you guys. Shelley, what do you think?
I think it looks great. Yeah, after you send it round, send it to me and I'll slap it on the logo if you want. You don't need to at this point.
Perfect. Yeah, exactly.
I will say, people who work with us on the Maternal Mortality Review Committee are really excited about this, just because we do see a lot of patients coming through that have been through EMS, and obviously it's not usually an EMS cause of death, but just knowing that some of these prevention strategies are getting around is really helpful for us. So thank you very much.
Yeah, no, I'm glad you brought it up. I think kind of after going through it, it was a little more, I don't know, I saw the extra value in it a little bit more than after going through the NCCP curriculum. I could see where this would be a really helpful, kind of different education for people to do. So
Awesome. Thank you.
super duper. Okay, well, I won't hold you guys any longer. I'll let everyone kind of get the rest of their day back, and I will send this around to the group right now. Clark, whenever you get a chance, send me whatever, and then I'll shoot it back to Shelley.
Okay. Thank you so much.
Cool. Thanks, guys.
Thank you.
Thank you.
Thank you, everybody.
Thanks, guys.
Later.